so good to be back with you all. I've been off the last couple weeks teaching, and I've got my partner in crime with me, and we are happy to be back with you Facebook Live tonight.
Hey, welcome everybody. This is Bill Richland, her partner in crime. We're excited that you've joined us here tonight. Just pardon me for a second. I'm just going to swap something out here because I've got the wrong order of us. I like my wife on my other side. She makes me look better that way when she's on the other side of the screen. So anyways, we are excited that you have all tuned in tonight. We've got an exciting program for you tonight. I know my lovely bride's been on the road a little bit, haven't you, darling?
I have been. It's been fantastic. I love wound care education, and it's been fantastic, but it's always good to be home as well.
Excellent. Well, we're glad to have you home as well, too. So we're kind of here in Wound Care Guru's Command Center. But I am honored to be able to present to you our esteemed guest for tonight. I'd like to bring to the show here Dr. Michael Miller. Good evening, Dr. Miller.
Doc!
Are you there, Doc?
Yes, I am.
Oh, there we go. We have him live. Excellent. Well, welcome this evening to Wound Care Guru's Facebook Live. We're happy that you could join us. I know we've got a very fun topic. Some people find it a little controversial, but you and I have never steered away from controversy in our past. Although tonight we obviously want to focus really on the nuts and bolts of behind what has been normally called Kennedy Terminal Ulcers for many years, and really what is going on pathophysiologically, so that our audience can leave tonight's interview with some good, solid information they can take back to, explain to their colleagues who may still be confused about it, and just bring some good evidence back to them. So we appreciate you sharing your wisdom.
I think there are others who might have other terms for it, but wisdom is okay for now, no question about it.
I'm between you two. That way, if you guys go off, I can kind of reel you back in, bring you back to the reservation, right?
My computer doesn't have to reach through.
All right.
Yeah, it's great. It's a great topic that's engendered a lot of controversy, and the goal tonight is to demystify it, decontroversialize it, and to kind of put some solid science in and let our friends and our viewers make some decisions for themselves as to what it really is, what it really means, and what are the things that we can do to prevent them, so to speak.
That is fantastic. Hey, Doc, I know I've really appreciated your friendship and your wisdom over the past 10 years, but not everybody knows you as well as we do. So tell us a little bit about yourself, your background, kind of familiarize anybody who hasn't met you.
Well, I'm a board-certified general surgeon, and in 1997, 1998, had the opportunity here in Indianapolis and vicinity to open a wound care center as part of a rehabilitation center. Prior to that, as a general surgeon, I had always done a lot of wound care and found that I was able to get stuff healed that no one else seemed to be able to do. And when we came to Indianapolis, decided to expand that, and in 1998 said to my lovely bride, I think I want to do wound care instead of general surgery. And her immediate response was, is this something that you can make a living doing? And I said, well, there's only one way to find out. So I resigned surgical privileges, put the word out that I was doing wound care. And from there, the rest, as they say, is history. And it's just expanded and expanded, and national podiums, international podiums, friends and colleagues all over the world. And the goal, like you guys, is to help. I never turned down a request for help. Always delighted to share the experience and teach what we can. And of course, at the same time, the chance to learn from some of our colleagues, because you can know a lot, but you can't know it all.
Amen. So true.
And that's the great thing about, learning and serving together, is that we can feed off each other, expand, collaborate, learn more. We're just on this wound specialist journey together. That's one of the things I love about our organizations. So, okay, so now I know that you decided to choose wound care, and thank you, because we don't have enough physicians in wound care. It is rare to find someone with your expertise, your knowledge, and yet still be willing to listen, talk to others, teach clinicians. What was that moment? What was that moment when you knew wound care was the thing?
It was when I realized that, again, this is all a lot of ego, but being a general surgeon, you're allowed that. It was just the fact that I was healing a lot of wounds that no one else was. They were saying, well, this has been here 6 months, a year. And I would look at it and say, well, this makes no sense. And then you start to see subtle nuances. Well, maybe this isn't why it's healing. Maybe this is why it's getting worse. And you make a lot of mistakes. And if you're smart enough to learn from your mistakes, then you get better and better and better. My goal has always been, and I tell people that I'm an intelligent guy, but sometimes I'm not smart. So I've always tried to make it very, very simple and oversimplify things. I talk about the 11 diagnoses in wound care. That's all there is. The 3 reasons the 3 things that you need to know to select a dressing. The more we can simplify it, the more amenable it is to everybody who does wound care. It's too easy to make it complicated, and after almost 30 years, it just ain't so. Wound care is very, very simple if you're logical. But please don't record that and don't tell anybody, because I don't want that secret to get out.
And I totally get that, Doc. I mean, I've always promoted with the students that I teach. Did you fall off your chair there, guy, or what? No.
No. I had something I thought came in. No, the cats have been abandoned. I thought I heard a scratch and thought, oh, no, I'm not letting one of them out.
But like I said, I've always challenged, when I'm teaching out there, I always challenge my students on 3 litmus test questions to every treatment. Number 1, what's your rationale? Does it make medical common sense that you would put A plus B and equal C? And number 2 is what's your evidence or your science? And number 3, can you defend it in court?
Yeah. I call that ready, fire, aim. And we see that on the Facebook post that we're on frequently helping people is they show a picture and immediately there's this frenzy of here's what I do and here's what I would do, here's what I would do. And of course, my first comment is, anybody out there have any idea of what the diagnosis is? Because you're all treating it, but nobody knows, nobody said what it is you're treating. And one of Miller's rules is there's no rule that says you're only allowed one disease at a time. Diabetic neuropathic ulcers, yes, that's great to offload and debride, but if you don't treat the venous disease above, you're not going to get them better. And the stuff that I see that's not done well is usually because of that. They're wearing their blinders and they're saying, well, here's the hole, see the hole, fill the hole. And, after years of doing it, it just ain't so.
Excellent. Well, let's get on with our topic. I know we got a lot of stuff to cover here. So I got my first question I want is, there's a lot of confusion, so much confusion surrounding KTUs in recent years. Why is that?
Because if you want to throw that slide up,
Sure.
I had the great honor of meeting Mary Lou Kennedy, who's a fellow Hoosier, and in Fort Wayne, Indiana, in '89, she astutely and the credit Mary Lou gets. Again, I had a pleasure of meeting her personally at Wild on Wounds 3, 4, 5 years ago when I was first considering the concept of what is still called the KTU. And the question was, how did you arrive at that? And it was observational. And again, basically what they discovered was that, at 8 o'clock in the morning when the nurses came on shift, a patient might have no evidence of pressure-based tissue injury. And then at 3:30, when they did report, suddenly they'd go in and there would be a pressure-based tissue injury or something, because arguably they weren't calling them pressure ulcers. And that would appear most likely in the area of the sacrum. And of course, what they then looked at is, why did this happen? And what they seemed to think was that there was a relationship between A, it only occurred in terminal patients, those that already had a terminal diagnosis, or B, those patients that developed this were soon discovered to have a terminal diagnosis. So the argument was, did this ulcer either A, represent an end stage of a terminal condition, or B, did it herald the presence of a terminal condition? Because again, they discovered that life expectancy after these occurred was about 8 to 24 hours. And it was observational and an interesting concept. And Mary Lou and her colleagues published a wonderful paper, a wonderful observational paper that in 1989, based on the pathophysiology we knew, seemed to make sense.
Got it. That perfect. So always the big question then. That was great history on that, and so I even learned something I didn't know. I mean, I knew she was from Indiana. I didn't know she was from Fort Wayne, but interestingly enough, though, we always when we run into these types of these wounds, pressure injuries, however we want to refer to them, we'll just call it a wound for now, ulcer, whatever, just generically. You always get the question: are they avoidable or are they unavoidable? And why? And why? Why? Which one is it? And why is that?
Okay. Do you have a slide for that?
I think I got something. Yeah, let me pull that up. There you go.
All right. So in the past, I've done a lot of medical legal work, and the question is, when a pressure-based tissue injury occurs, what are the reasons that they occur, despite your best attempts to prevent them? And that would be, of course, rotation, changing position. Well, the easy, low-hanging fruit, of course, is patient compliance. And having reviewed hundreds and hundreds and hundreds of charts, the documentation doesn't have to be super textual. If you're writing down your thoughts and what's happening in patient response, that's enough. So if you're telling Dr. Miller that he needs to get out of bed, he cannot sit at 45 degrees when he's watching TV, he's got to go right hip, he's got to go left hip, he's got to sit at 90 degrees to take the coccyx out of play, and Dr. Miller continues to develop that, and every time you see him, he's at 45 degrees, you've got a compliance issue, and you would document. I've told him he's not listening, he refuses to change, and so that case, the ulcer would be unavoidable, and the reason would be non-compliance. But you need to document it. Do you need to document it every time you see him? It would be nice, but if 30-40% of the time you see him, you say he's not listening, he's still on it, it's getting worse, any good medical legal expert reviewing your chart is going to recognize that 30-40% non-compliance is non-compliance. The second one is the hemodynamic instability. We still see this, but even in the hospitals, the ICUs, where a patient is on multiple pressors and other things, whereas, as they jokingly say, if you cut their hair, they might die. In a patient, that turning them would compromise them because they're hemodynamically unstable, or the position of the tubes and wires and hoses. In those cases, a patient that develops a pressure-based tissue injury, you could make a good argument that that was also unavoidable. And again, the hospitals are now doing a fabulous job getting better support surfaces that envelop. And so you no longer have point pressure, you no longer have single area pressure. It's now spread over, the envelopment concept that a lot of the bed manufacturers are using. And so we don't see much of this hemodynamic instability. The last concept is the one that's kind of in evolution, and that's the one that more commonly is called tissue failure.
Awesome. All right, terrific.
And that's what we're going to talk about.
All right, excellent. So we are very aware, obviously, of those clinical observations. You alluded to a lot of them from what Karen did back in the day that are associated with Kennedy Terminal Ulcers, as I like to call them, KTUS. But what is really going on pathophysiologically then, so that we can understand the origin of these wounds?
Okay. And again, one of the most common things, if you're going to call an ulcer a pressure-based tissue injury, which is my terminology, I want to make that clear. I understand they're still calling it pressure injuries. I have a lot of problems with those terms. They're poor descriptors, but that's a program for another day. But again, sticking to my PBTI concept, it's all pressure-based. Pressure-based tissue injuries are caused by pressure. Attorneys will ask, well, they're diabetic, they're malnourished, they had sepsis, they had pneumonia, they had dementia, they had whatever. Do those not all contribute to the development of a pressure-based tissue injury? And my response is those contribute to the factors that relate to the development, but pressure-based tissue injuries are caused by one thing and one thing only: pressure. And if you had someone that lived in the time of George Jetson and the Jetsons, and they could hover in the air, then even with all those other factors, they would never develop a pressure-based tissue injury because there'd be no pressure.
I think you talked about the point, or the thing, we had a slide here we put together on stressors. If you want to just kind of...
And this was why when I first looked at this concept and I said, it's an extraordinary piece of observational work, but pathophysiologically, based on what we know, it didn't make sense. And so when I looked at it, I started to think in terms of what kind of things stress the tissues. Well, you're talking about, events occur at the cellular level. And if it occurs at the cellular level, then it occurs at the tissue level. And if it occurs at the tissue level, it occurs at the organ level. And if it occurs at the organ level, now you've got a systemic. So in patients with cardiac disease, you pick it, respiratory disease, endocrine disease like diabetes or renal, that those are systemic stressors. They affect every tissue of the body. And while a specific end organ may be targeted, such as the heart and cardiac and the lungs, that the effect of that systemic problem affects every tissue and arguably affects every tissue equally. So a patient with CHF, you're going to have some effect in their fingertips, in the ends of their toes, in their kidneys, and of course in their skin. And those are systemic stressors. Then I said, okay, with the concept of systemic stressor, why then, according to the theory of Kennedy Terminal Ulcer, why does one and only one area break down? And I said, well, then there has to be something that is affecting just that area. And the rationale, I said, was, what else could it be? And I jokingly said, it's not as if the human brain suddenly and arbitrarily decided to, let's break down the sacrum. It just doesn't work that way. Your brain just doesn't argumentatively select an area to have tissue breakdown. There has to be a stressor. And we know now, and especially some new research coming out that I don't agree with totally, but conceptually, it's a blood vessel problem. If you cut off the circulation, if the capillaries don't feed the area, then what happens is that particular area gets no blood supply and that tissue dies. Now, we were talking a little bit before, Bill, about a new concept where they're talking about compressing vessels proximal or above the ulcer, and that leads to pressure-based tissue injuries.
Right.
And the problem I have with that is that you've usually got such greater collateral circulation around the wound that if I cut it off in this direction, or I cut it off in this direction, or this direction, you still have another 270 degrees worth of circulation to feed it. And so cutting off a single vessel doesn't do it. It's got to be circumferential, and that's usually direct pressure. And when I looked at that, I said, okay, well, why would it be in this area only? Two concepts. Well, trauma. Well, it's quite unlikely that someone is going to punch a terminal patient in the sacrum for any reason. And so taking trauma out of play, the only thing realistic would be pressure. But I call that concept point stressors, and those are things that affect a single point. And when you look at the way these develop, these patients are on their back. And so again, it's a pressure consideration since it is now applied to a single area. In the framework of a systemic stressor, this local point stressor then causes what is more commonly known as a Kennedy Terminal Ulcer.
Excellent.
Those are great points, Scott, because I always wondered myself, why do we not see anything in the hands? Why do we not see anything in the toes, and yet it develops on the sacrum first? So that clears up a lot of confusion that I had over the years.
Correct.
Right.
And that was one of the issues we talked about, and we talked about medical legally. That's why when these develop, you scratch your head, because we're all trained that the treatment to prevent pressure-based tissue injuries is not dressings, it's position changes.
Right.
And the 2 hours, and it's funny, I did a huge amount of research trying to figure out where that came from, and if any of our listeners can get me information, the best that I could find about a 2-hour turning was an article I read where they talked about staffing, and they found that with staffing and with all the stuff they looked at going on in hospitals and skilled facilities, that 2 hours seemed to be the most reasonable amount of time that you could expect someone to be able to get to and help a patient change position. Not very scientific, but again, anecdotally, it just seemed to be 2 hours. Because again, the research shows that you get tissue damage, ischemia, happening within minutes. So the 2 hours right now is still unscientific, but that's kind of the gold standard that we talk about.
So how exactly, I got this slide up here, you talk about a point stressor becoming a systemic stressor. How exactly, break that down so that's understandable to us?
Sure. If the systemic stressors, hopefully everyone understands. Diabetes affects cells, tissues, organ systems, congestive heart failure. So you've got these systemic stressors. Why then does a single area only become that? Well, the key then is if you can turn that point stressor into a systemic stressor, then you have a better idea of whether or not it is truly pressure, and more, whether or not they are in this concept of tissue failure. And so the question was, if I said I have a patient and I'm going to turn them and change their position every 2 hours, that means that the sacrum gets 2 hours of pressure, the coccyx, 45 degrees from flat, gets 2 hours of pressure. I sit them at 90. Now the ischiae are getting 2 hours of pressure. I roll them on the right side. The right hip gets 2 hours of pressure. I roll them on the left side. That's 2 hours of pressure. I understand that prone is probably not going to happen, so we won't discuss that. But if I'm moving them and putting them on those other areas every 2 hours, then I have turned a point stressor into a systemic stressor, because now each of those areas is getting the same amount of stress, pressure, as the sacrum is. And that's the concept. If indeed you do that, then if they break down in a single area, that can only mean you're not turning them, because the expectation was if you've now turned a point stressor to a systemic stressor, then you better see pressure-based tissue injury of the right hip, of the left hip, of the ischium, of the sacrum, of the coccyx. Now, they don't all have to be a stage 4, arguably. I mean, if the sacrum goes necrotic and the buttocks, because they have more fat, maybe only go to a stage 2, that wasn't the point. The point was that if you're going to tell me you're turning them every 2 hours, you've turned a point stressor into a systemic stressor, and every tissue so affected should show an effect similar to all the other tissues that are affected.
That makes perfect sense. Just physiologically and common sense and logic. So, excellent.
Right. Now, the other concept we talked about, and we talked before that, was the fact that the Kennedy Terminal Ulcer has been used as a bulwark, but the problem is they've used it illogically. The case I saw where I did the plaintiff's work, where a plastic surgeon who was trying to protect the home, and I think that's important, that facilities need to have the benefit of the doubt. We recognize they're busy and whatever, but this gentleman said it's not preventable because it's a Kennedy Terminal Ulcer. The problem with that case is that, one, the ulcer healed, and two, the patient didn't die. So that poses problems on two fronts.
This is just a little problem there.
When they don't die, it was an interesting case to review, and I just kind of scratched my head and say, I don't mind reaching to help, but this guy's leaning out over a cliff hanging by his toes.
Right. So in your mind, how should we classify them then? Pressure injury or skin failure?
I think they're pressure. I mean, the fact that it's skin failure sets the stage. But as I said earlier, if we lived in the era of George Jetson and I had someone dying, with tissue failure, if I hover them in the air with no pressure, pressure is the only thing that causes pressure-based tissue injury. Nothing else. If it's a toe, that's arterial ischemia and venous and whatever. Tissue failure sets the stage for pressure-based tissue injuries, but they're called pressure-based tissue injuries, not tissue failure injuries.
Excellent. So I know you kind of alluded to the slide up there a little bit earlier.
Yeah, and that's why this didn't make sense to me. That number 2 really was the most poignant, as I kept saying, if it's a terminal ulcer, why the sacrum? Why not, as Denise said, why not the hands? Why not the toes? Why not the head? What would make the brain, in all cases, pick the sacrum? And then I said, well, these patients are laying in bed. They're laying in bed. And what contacts the bed when you're laying? Sacrum. So always sacrum, then it's positional. It's not some unknown phenomena. And again, the problem was all they established was that there seemed to be a relationship, but they never established causality.
Gotcha. So, go ahead. I think you had something else then, Denise.
Yeah, I was going to say, so kind of talk to us then about some of the legal implications, what our audience should be aware of as we're dealing with these.
Well, it's actually, and as I said, I try and keep things very simple. And this is how to keep it simple: is not only do you document that we turn them every 2 hours, if you can. And sometimes that's impossible. We work with facilities and we do a huge amount of house call wound care, and it's tough to turn somebody. There's no question. But my point is that if you are turning them, even at less than greater than 2 hours, I should say, then if they're going to get pressure-based tissue injuries, they're going to get them in other areas. And again, if they are truly terminal with tissue failure, then there's not much you're going to be able to do to prevent those, even turning them. And for better or worse, that's kind of the medical legal saving grace. If I see an injury on the right hip that's a little soft and the left hip's got some skin off it, then you're going to see those other areas. And I took the liberty of coining this Miller pressure equivalent injuries, and arguably that's what you should have occurring if you have a patient that is quote unquote terminal or not terminal. But if you want to prove that you're turning them, and they develop an injury, a pressure-based tissue injury, then every surface you're turning them on should A, develop some sort of pressure-based tissue injury, and B, should be getting better equivalently as they respond to your treatment.
Excellent. And I know we just for the audience sake, we cited on the bottom of the screen there Dr. Miller's article he published a couple of 2016, I believe. And if you want to Google it, if you just Google "death of the Kennedy Terminal Ulcer," you get a link right to that article. It's a great article that kind of obviously covers more in depth than even what we're discussing here tonight on it. So I just wanted to point that out if anybody wanted to look that up for some more information. So I guess my next question then, Doc, really is, so now that we understand the pathophysiology going on here, and I thought you've done an excellent job of, I think, breaking that down and making it fairly understandable for people. What are best practices then for managing them?
Well, again, the simple Miller tenets, the treatment of pressure-based tissue injuries is pressure relief. And it's amazing because when I ask people that question, and the goal is to just kind of get them to think, invariably it's lots of you need to identify if they're malnourished or infected or all this other stuff. And it's like, no. What's the cause of pressure-based tissue injuries? Well, it's pressure. Then what's the treatment? Pressure relief. Nutrition is important to promote healing, but lack of nutrition is not going to cause you to develop a PBTI. Infections, again, that's a topic for another day. Anyone who's heard me lectures will know that I don't believe in wound infections. I think they're pretty much a myth. We rarely, if ever, use antibiotics in our practice, and we're healing almost everything. There's certain examples, osteomyelitis, diabetic foot ulcers, but I can't remember the last time I used an antibiotic in a venous ulcer or, God forbid, a pressure-based tissue injury without bone exposed, of course. So,
right.
Lots of anecdotal stuff that's still being perpetuated and perpetrated. But, the treatment for pressure-based tissue injuries is get the pressure off, Because what we see is people, when they're sick, they put them in bed. And, of course, the most common position people are in bed is TV watching at 45 degrees. And you get the sacrum, you get the coccyx. And, we get in there and say, well, their butt bones are fine. Sit them up at 90 degrees. And suddenly this sacrococcygeal thing erupts into healing. And everyone's kind of scratching their head. And the patient, of course, is happy. Because the ultimate goal of all wound care should be quality of life. Right. Putting them in bed in their own bedroom with no one there sucks. If you can get them to 90 and get them out in the room with the kids off from school and whatever, that's what people really do well. And that's why the home-based care, at least in my opinion, is the way it should be. Hospitals in, take care of the emergency, get them out, bring them home.
Excellent. That's some good information on there. Now I know that you alluded a little bit to this new theory. You talked about it that is starting to make some traction around the industry. And just for one more time, again, just so that our audience is aware what's out there, what they're saying, just so if they run into this, they understand and at least have a perspective from somebody who's obviously quite well researched in terminal wounds and what pathophysiologically really brings them to this point. Kind of just recap that again so our audience is prepared, so they understand a little bit behind what's going on and what that thought is and what your professional expertise and opinion on that is.
All right. It's basically what the thought is that there are multiple vessels feeding, the tissues. And again, everything is capillary based. That's the one bugaboo I have about a lot of this amputation stuff, is that the bypasses and the stents are great, but no one, with exceptions such as myself, is treating the microcirculation. I call it the Iowa cornfield. If I bring water and surround a cornfield in Iowa with water, but I don't get it down to the corn, I'm going to have a field of dead Iowa corn surrounded by water. If you don't get it down the rows and to the plants. And so recognizing that everything is microvascular, the theory is somewhat contra to that. It basically says that there are primary feeding vessels to certain tissue areas, and that by obstructing those, and that can be with pressure. But remember, in the deep tissues, there's what I call true pressure, which is perpendicular. There's friction, which is on the skin, and then there's shear, which is deep tissue layer on deep tissue layer. Right. When you're on the deep tissues, you are disrupting the capillaries that go from layer to layer. And so that of itself, it may not be true pressure, but it's still pressure-based. You can't have friction or shear without that. So the theory, again, is that there's a primary feeding vessel or vessels to an area, and that obstructing them or compromising them leads to this. And I just can't get my teeth into it because I can't understand how the microcirculation would be unidirectional. It's not. When you blanch your thumbnail, it blanches uniformly. It doesn't blanch from the top down or anything. And so I'm interested to see how they're going to prove this. Right now, to my understanding, it's still just a theory. I guess the be-all, end-all is, what does it really mean in the grand scheme of things? Because it's still a pressure-based tissue injury, and the answer to the problem is, get them off.
No doubt. The basic rule number one, remove the cause, right?
That's it. And we see that. I mean, that's the funniest thing. And again, the whole, one more anecdotal, is it always happens that I go into a facility and they've said, oh my gosh, this is worse. And we're doing the orders you gave us, and the injury is, the bed sore is getting worse, the pressure-based tissue worse. What do? And I walk into the room, and let's say it's a coccygeal, and the patient is sitting at 45 degrees, which is coccygeal pressure. And they say to me, oh my gosh, we just put her back to bed a half a second ago. Literally, she was outside. And my response is, there are 365 days in a year. There are 12 months in a year. There are 30 days in a month. There are 24 hours in a day. There are 24 hours in a day, 60 minutes in an hour, and there are 60 seconds in a minute. And you mean to tell me that of all of that time, I came in at the exact second where she's on the area that she's at? It's amazing. It's a miracle. I picked the only time in that space. In other words, you're not turning her. And again, it's a big equal sign. The only reason pressure-based tissue injuries get worse is pressure. If it's getting worse, you're not taking the pressure off. Nothing else makes them worse. Infection does not make them worse. It prevents them from getting better. And necrotizing fasciitis notwithstanding, of course. Sure. It won't get better if they're malnourished. It won't get better. But the thing that makes them worse is pressure.
Awesome. Now, before I got one more question for you, just to get some of that. But if any of the audience has any questions for Dr. Miller, please throw them in the comments box. He would be more than happy if there's something he said that you need some clarification on. Throw those in the comments box, and we appreciate the comments we've gotten thus far. But Doc, as we're kind of coming to an end here and seeing if there's any questions, are there any final thoughts on the whole KTU, the Miller-based pressure injuries that we have not already covered that you feel would be helpful to the audience?
Not really. Again, the keys are to make a diagnosis. The question is why? Most of wound care is a diagnosis and then an equal sign. A venous treatment of venous insufficiency ulcers is compression, period, end of discussion. And you need compression at, as we've discussed 1,000 times, 50 millimeters of mercury. Less than that doesn't do it. Not having it continuous in a non-ambulatory patient doesn't do it. Arterial ulcers, maximize, major and micro circulation. And again, no one is treating microcirculation, and I've been lecturing about it for years, and I get lots and lots of interest and lots of excitement, and God only knows who's doing the stuff we're doing, and our amputation rates are lower than low. Same with pressure. If you've got a patient that's prone, it's not just some of these phenomenal support services that are out there, because unless you are getting them below 32 millimeters of mercury, and that's capillary closure pressure, but that's healthy people. Our elderly are way below 32.
Right.
So unless you can get that capillary open and feeding, you're not going to do anything. The dressings, we have some reps that are touting foam dressings on intact skin. And my argument is, I want you to put the dressing on and I'm going to punch you and let me know if you feel it or not. And of course, I never do, but the dressings are not for great. Yeah, they're absorption, There's just lots of illogic out there. It's trying to reach out to get help. And the question is, hey, what's your diagnosis and your treatment? Dressings, 3 concepts. Where's it located? How much drainage is there? And what are you trying to do? Get rid of slough, grow epithelium, absorb drainage, and that's it.
Right.
Where's it located? What are you trying to do? And how much drainage? And those 3 things, you can find your friendly neighborhood rep and just say, hey, I know ABC, give me a dressing, or give me 2 dressings, and you're done. It's not important to worry whether or not you're going to use a Smith & Nephew or a Medline or and God knows anybody else, a KCI dressing, Lots of fabulous dressings, but the dressings are not the treatment. We are.
Amen. Excellent. Well, we certainly appreciate your time this evening, Doc. It's been a wonderful educational opportunity. I know our audience certainly appreciates that. Did you have something there, sweetheart, you wanted to add here?
Just wanted to say thanks, Doc. I always appreciate your wisdom and the fact that you can just cut to the chase and make everything so clear.
Yeah, that's why my middle name is controversial.
Well, we will let you go. We'll let you go, Doc. Thanks again, and we will talk to you again real soon.
Thank you both. Thank you, audience. I'm available for questions.
That's right. The Doc Miller. I almost forgot.
Doc Slide.
Thanks. Good call. Go ahead.
There we go. And again, thrilled, delighted. For better or worse, I get requests from all over the world, all over the United States, people saying, what do you think? What do you think? And again, I'm honored to be asked and promise that I will always give you the best thoughts that I have on whatever it is. We are all in this together.
Excellent.
I had my question pop up, and it says, if we needed him to consult, how do I find info on this?
Right there. Email me.
Email you. All right.
Say, here's what I got, and what do you think? I tell people, anytime you want to send me, and you know what? I forget what game show it was. I can name that song in 1 note, 2 notes, 3 notes. Is the fun I have now is trying to figure out what the cause is with as little information as I can. And it's a neat exercise. But usually I like 2 pictures, one from 6 inches away and one from about 2 feet, so I can see the geography and the anatomy. And then the other thing I need to know is what is the treatment that you are currently doing, or what treatments have been done. And then, like I said, then it's up to me to guess the name of that wound. And, I can do that in 3 facts or less, or 4 facts or less.
Excellent.
A few more than that.
Yeah, and sometimes. But you know what? Most of the time, and you guys, same experience, it's fairly simple. It's a venous ulcer, and they're doing everything except compression.
Right.
Or they've got the ulcer, and you can see necrotic edges, and they say, we can't figure out why that's there. Well, we know why it's there. Pressure. The overwhelming majority of these are right in front of our faces. You just got to make that diagnosis. Of which there are 11.
11, yes. I have touted those 11 diagnoses many times in my seminars. So
maybe we can have a Facebook Live on the 11th. That might be a good one.
That'd be funny.
That would be good. 11. All right. Well, thank you again, Doc. We appreciate your time. You have yourself a great rest of your evening.
I will. Thank you both for inviting me. Audience, thank you. I'm humbled and honored to be of any assistance I can.
All right. Thanks again. You take care, Doc.
I will. Bye-bye.
All right, everyone. That kind of brings tonight's Facebook Live event to a close. We want to thank everybody who tuned in. And, of course, anybody who's watching this on recording after, We obviously thank you for tuning in at a later time and watching it. We hope you found this information to be extremely helpful in your practice, because that's really what we're all about here at Wound Care Gurus, is to bring the truth, to bring the facts, to bring the science. No voodoo medicine, no dabbling, no shotgun medicine here. We want you guys just arm you with the facts so you can go back and really have the outcomes you want to have with your patients. Anything there you want to add, my love?
No, just fantastic presentation tonight. Can't wait to see what's up for next week.
All right. Well, I want to thank everybody for tuning in. This is Wound Care Gurus. We are signing off.
Thanks, everybody.
Thanks. Take care.